Okay, shall we start then?
Yes.
Okay, right. So good evening and welcome to the webinar, an update on glaucoma. This is organized by the Eye Care Center of the Faculty of Medicine, University of Colombo. So on behalf of the Eye Care Center, Faculty of Medicine, University of Colombo, I would like to welcome all of you to this webinar. Especially, I would like to thank and welcome our panelists today. If I were to introduce them, Dr. Lalita Senarath, who is a consultant eye surgeon working at Teaching Hospital Karapikya, and also she is the Glaucoma Focal Point Vision 2020 program. And also Dr. Pradeepa, she is a consultant eye surgeon at National Eye Hospital, Sri Lanka, and also the chairperson of the Glaucoma Interest Group, College of Ophthalmologists of Sri Lanka. So I am extremely thankful to both of them for joining us in the midst of their busy schedules to make this webinar a success. Actually, the Eye Care Center, this is the first time that we are joining the activities of the World Glaucoma Week. And Dr. Pradeepa Kesariwardena is the center point for the glaucoma activities in Sri Lanka. So this time we have organized several activities which include actually this webinar on glaucoma for doctors and medical students especially. And also we have organized a social media campaign on glaucoma by the undergraduates especially, and a screening program for the staff and the general public, which will happen in the coming week. Also, I would like to thank everybody who is behind all these activities, especially the College of Ophthalmologists of Sri Lanka and the Faculty of Medicine led by the Dean, Senior Professor Vajra Disanayaka, and the team at the Dean's office, as well as the Family Medicine Unit, who would be helping us with all these activities. And also our colleagues, especially I would like to mention Dr. Roshan Hevapatirana, who is helping us with all the IT activities. So without further ado, I would like to get on to the topic. In today's webinar, we would be actually touching upon glaucoma as an update on glaucoma. So initially, I would be doing the introduction as the Director, Eye Care Center, UCFM. Then Dr. Lalita Senarath will be touching upon the investigations in glaucoma. Lastly, Kesariwardena would be elaborating on the treatment options. We would like to keep the questions to the end. You can send in the questions in the chat box, so we would take them towards the end. So getting on to the topic, glaucoma is also known as the silent thief of sight. So that means the patients, most of the patients would not know that the vision is being threatened. So that is why the vision is slowly taken away from the patient. And that is why it is very important for us to have this. So if you go to the definition of glaucoma, there are several definitions. Glaucoma is a group of diseases. It's not only one disease, it's a group of diseases. And it's a progressive optic neuropathy. That means it affects the optic nerve. And the characteristic appearance of the optic nerve is special to this disease. And also the visual field defect is also has a specific pattern. And contrary to the popular belief, intraocular pressure rise is not always associated with glaucoma, but most of the time the intraocular pressure or the pressure inside the eye is causing the damage to this optic nerve. So what happens actually is the intraocular pressure, which I will tell you how the pressure builds up, will be affecting the optic nerve at the back of the eye. So taking the problem in its magnitude, so if you take glaucoma, it is the second major cause of blindness, the first cause being cataract. And why it is so important is it is often asymptomatic in the early stage. And the other thing is, not only that it is asymptomatic in the early stage, but the damage that is done is irreversible. So unless we catch the patients early, we are unable to do anything for these patients. And the other important thing is, if we catch these patients early, they can be treated effectively. So therefore, it is our duty as doctors to find these patients, diagnose the disease early, then treat them appropriately. And the burden of glaucoma is found to be increasing in the future. So the future the forecast shows that 76 million in 2020 glaucoma patients would be increasing to 111 million in 2040. So you can understand the magnitude of the problem. So let's just talk about the pathophysiology or how this glaucoma occurs. So as you know, the eye is a ball, and inside the eye there is a fluid. So there are actually two types of fluid. So the one that is in the anterior compartment, that is the anterior chamber, and the posterior chamber would be the aqueous humor. And in the vitreous cavity, you would find the vitreous humor. So this aqueous humor is secreted from the ciliary body, from the ciliary processes. This aqueous humor is secreted, and how it gets into the drainage pathway is through the posterior chamber, that is between the iris and the lens, and then it goes through the pupil and then enters the anterior chamber. In the anterior chamber, as you already know, it enters the trabecular meshwork. And from the trabecular meshwork, through the Schlemm's canal, it enters the episcleral venous plexus. So this production and drainage should be in a balance. If the balance is upset, then the pressure will be different. So if the production is less, then we know that it's a different disease condition and the eye will shrink. So that is the phthisis bulbi, or the eye will shrink. But here, on the other hand, in glaucoma, what happens is what is produced in the ciliary processes is not drained properly through the drainage canal, that is the trabecular meshwork. So then the eye pressure or the pressure inside the eye will increase. So before we get on to that, we'll see is what are the ways of this aqueous pressure getting out of the eye. So what are the main ways? About 90% of the aqueous drains through the conventional pathway, that is through this trabecular meshwork and the Schlemm's canal. But about 10% would go in different pathways. That is, the uveoscleral pathway is there, and also some aqueous will get absorbed through the iris. So it's important for you to understand this because the treatment options are targeting different pathways. So let's get on to the next stage. That is actually the normal pressure is between 11 and 21 millimeters of mercury. But this is just a range. So patients can have 11 or 21 as long as the optic nerve is not damaged. It will not harm the vision of the patient. Now, not only you have to know the normal IOP, but also you have to be aware of other factors that would have an effect on the IOP. So I have given the list of things that can have an effect on the IOP, that is intraocular pressure, such as age, sex. The race would be the pigmented races, or the colored races will have high IOP, and hereditary, if the siblings or family history is there, then it will affect the IOP. Then diurnal variation, that is in the morning, the IOP is higher than in the evening. Also, it will increase with the blood pressure and with certain drugs and posture, exercise, hormones, as well as several other factors. So let's get on to the theories of optic nerve damage. So how can this intraocular pressure damage the optic nerve? Actually, there are three main mechanisms so far postulated. That means first one is the mechanical theory. That is direct pressure causing compression of the axons that are found in the retina. So what are these axons we are talking about? These are the ganglion cells. So you know the photoreceptors, and from the photoreceptors, the bipolar cells, and from the bipolar cells, the stimuli, the bipolar cells will cause stimulation of the ganglion cells, and the ganglion cells will have the axons, which will be exiting the eyeball through the optic nerve head. So this is the optic nerve head, and about 1.2 million axons will be going out through this exit. So this is where the pressure inside the eye will have an effect at this point. So here, the first theory, according to the first theory, mechanical damage, the direct pressure will cause damage to these ganglion cells. The second theory is the vascular theory, where the pressure would cause the tiny blood vessels, the capillaries, supplying the optic nerve head and the ganglion cells, and cause ischemia. So this ischemia will cause axonal necrosis. The third one, or the latest theory, is the metabolic theory, where the pressure inside the eye will cause interference or impedance to the exoplasmic flow of these ganglion cells. And this will lead to accumulation of toxic substances, and these toxic substances will cause damage to the optic nerve head. So these are the theories. So there are a lot of research going on. So depending on the theories, there are so many drugs that have been developed. So how would we know that the glaucoma is progressive? In the beginning, I said that the glaucoma is a progressive optic neuropathy. So it's not static. That is why we have to monitor the patient. So what are the things, or what are the factors that we would consider to see whether the patient is having a progression in his glaucoma, the disease of glaucoma? So increasing CD ratio or cup disc ratio, as you know, the vertical diameter, this is the cup, will be increasing. The other thing is the disc tallow also will increase gradually. Then also another important feature is the disc hemorrhage. So if you see a disc hemorrhage in a glaucoma patient, then it is important for you to see the patient more frequently to see whether he is going into uncontrolled glaucoma, and whether you need to step up his medications. Then also the vessel displacement. So as in this picture, you can see in the right hand upper corner picture, you can see that the blood vessels in the optic nerve head has been displaced. So that is vessel displacement. And also you can see the visibility of the lamellity. These will we'll see that they become slit-like. From the tiny dot-like spaces, they will become slit-like spaces. So that is also another way that we can see that the glaucoma is progressing. So now we come to another concept in glaucoma. As I said earlier, glaucoma is a group of diseases, a heterogeneous group of diseases. So how are we going to classify this? So one way of classifying is whether there is any, whether the glaucoma is primary or secondary. That is, if there are no other associated ocular or systemic factors, then we say it's a primary glaucoma. But if there are predisposing ocular or systemic abnormalities such as trauma or inflammation or any other developmental abnormality, then it becomes a secondary glaucoma. So usually primary glaucomas are bilateral and often familial, but secondary glaucomas happens sporadically and usually they are unilateral. Now, out of the primary glaucomas, one important factor that we have to consider is the appearance of the angle. So depending on the appearance of the angle, we divide them into open angle glaucoma and closed angle glaucoma. What is this angle? This angle is the iridocorneal angle. This is the iris, so iridocorneal, cornea. So iridocorneal angle is the angle that we are talking about. Why is this important? Because this is the key area. Trabecular meshwork is present here. So in open angle glaucoma, you can see that the trabecular meshwork is open. The iridocorneal angle is quite open. So you can see that the aqueous humor that is produced in the ciliary body can, without any problem, enter from the posterior chamber into the anterior chamber and then drain through the trabecular meshwork. However, opposed to that, in the closed angle glaucoma, you can see, although the iridocorneal angle is supposed to be there, it is covered, it is closed. So this is the closed angle glaucoma. So we will see actually what makes this angle to close. So this is the main difference between the open angle glaucoma and the closed angle glaucoma. So when we see a patient, we have to see whether the patient has an open angle or a closed angle. We use a special lens called the gonioscope to see this iridocorneal angle. Right. So out of the glaucoma types, one very important type of glaucoma is the primary angle closure glaucoma, which is actually a medical or an ocular emergency. So this is an acute congestive attack. So as a general practitioner or as a person who is at the primary contact level, if you see a patient like this, you have to identify this, you have to diagnose this, and then immediately take action to treat this patient. So how would these patients present to you? These primary angle closure glaucoma patients will have sudden onset pain in the eye, and there will be redness around the cornea. So circumcorneal injection will be there. Also, the patient will complain that he or she, usually a she, female patient, will complain that they are seeing halos or colored rainbow-like appearances that is due to the corneal edema. And then when the corneal edema increases, there will be loss of vision. Sometimes the pain will be so bad that the patient can even have vomiting and abdominal pain, so that sometimes these patients are admitted to the medical casualty in a hospital. So therefore, you have to always check whether the patient is having any eye condition when they come with these any acute angle closure glaucoma, when these patients present like this. So when you examine the patient, when you check the patient's eye, you will see that the eye is stony hard, sometimes very hard if you touch, and the patient is in a very debilitated condition. Clinically, you can see that the patient is very sick, and there will be shallow AC. The AC will be, anterior chamber will be shallow, and the cornea will be edematous. That means it will not be clear. You will not see through the cornea as in a normal patient. And also the pupil is characteristically dilated in a patient presenting with acute angle closure glaucoma. So you have to identify this. So when you look at the patient through the slit lamp, you will see that the anterior chamber is very shallow. So let's see what happens here. So when there is aqueous humor produced, and when it comes through here into the posterior chamber, there is a pupillary block. So what is a pupillary block? When the pupil dilates at one point in susceptible patients, you can get apposition of iris and the lens, and therefore the aqueous humor cannot exit through the pupil. So there is bulging of the iris, and this bulge will go and cover the iridocorneal angle and the trabecular meshworm. So then what happens? The more aqueous that is produced will make this condition worse. So we call this iris bombe. This is like it makes a convex contour like this, and that is called the iris bombe. And this will cover. Now initially it will be like this in the top picture, then like the middle picture. Later on the condition will get worse, and it will totally cover the iridocorneal angle, and that is where you get the acute angle closure glaucoma. Okay, so now let's go on to the next type of glaucoma, that is primary open angle glaucoma. This type is the typical silent of. So here this is actually the most common type of glaucoma, and it is also called chronic open angle glaucoma. Here the damage occurs very slowly. This is a chronic type. So what are the features here? It's usually adult onset, and the intraocular pressure is more than 21 millimeters, whereas acute angle closure, the pressure will go up to 40s and 50s. And the visual field. There is another entity also known as low tension glaucoma, which is quite prevalent in Sri Lanka as well. So mostly elderly people, and the pressure is less than 21. Usually we say that the pressure should be more than 21 to be primary open angle glaucoma, but in these patients the pressure is less than 21. However, there will be optic nerve head changes as well as visual field defects. They are usually associated with other systemic diseases. So remember that there is this entity, low tension glaucoma, as well. Then let's get on to the secondary open angle glaucomas. So this is actually the angle is open. However, what happens is the drainage is affected by different factors. This is called secondary because all these factors are coming due to a different outside reason, sometimes within the eye, sometimes systemic cause. So take for an example, some of the causes. Now I take this example of a kitchen sink. Now, if you have a kitchen sink, you will have the drainage area, the drain. So if something is kept above the drain area, suppose a large dish or something is kept covering the drain, then you will not get any drain through this kitchen sink. Okay, so similarly, there can be epithelial membranes, endothelial membranes, fibrovascular membranes, and inflammatory membranes. So they will go and they will form a membrane covering the iridocorneal angle. Okay, so they will go and cover the trabecular meshwork. Okay, you can still see the angle here, but the trabecular meshwork is covered, right? So these are pre-trabecular types of open angle glaucoma. Then we have the trabecular. That means certain things can go and block the trabecular meshwork. So what are these things? Like in a sink that you will get rice grains and other things like that. So in the eye also, these tiny holes are blocked by red blood cells, white blood cells, red blood cells in trauma when there is blood inside the eye. So these blood cells will go and block. Inflammatory cells, neoplastic cells, pigments such as those things will go and block this trabecular meshwork. Then there is the type which is known as the post-trabecular type of open angle glaucoma, secondary open angle glaucoma. So here what happens, it's like the drain away from the sink. If you have some other block away from the sink, it's something like that. So here we have SVC obstruction, thyroid eye disease, AV fistula, Sturge-Weber syndrome. So these things can cause the episcleral pressure to go up. And this is called the post-trabecular secondary open angle glaucoma. Okay, so these are the different examples of secondary open angle glaucoma. Another interesting entity is the neovascular glaucoma. This is a very refractory type of glaucoma. You will see rubeosis iridis, that is blood vessels over the iris. Here the pathophysiology is due to ischemia of the retina due to different causes such as diabetes, central retinal vein occlusion, artery occlusion. The retina becomes ischemic and there is neovascular formation of new vessels, and these vessels will form in the angle as well, and then it will cover the trabecular meshwork. Okay, right. So this is my last slide. So in over to you, Lalita.
Thank you very much, Madhuvanti. Thank you very much for the kind invitation to address on this very good clinical meeting on glaucoma for medical officers and the medical students. Roshan, can I share the screen or what?
Yes, you should be able to share the screen.
Can you see the screen, Mike?
Yes, we can see slides.
We'll go to the slideshow. The first one, right. Yes, today I am doing the diagnosis of a glaucoma, especially how the patient labeled as glaucoma suspect, and just we have to just work through this patient is having glaucoma or not. Actually, the glaucoma diagnosis can be just mainly by the clinical diagnosis and the other investigational diagnosis. The clinical diagnosis is actually discussed by Dr. Madhuvanti. Now, I am just mainly touching on the other, how what are the tests you do to make the diagnosis to confirm the patient is having glaucoma, and how do you label the patient? How do you think this patient may get glaucoma or not? Then we'll see the glaucoma suspect, right? You should just, from the medical students and the medical officers who are the primary doctor, will see a patient. Usually, as Professor Mandhavan said, the patient does not have any symptoms. Therefore, when you're seeing a patient, don't forget, just look at the eye as well as look at the fundus and the optic nerve head, because we are doing some training for you, hands-on training during your as a medical students as well as medical officers. Therefore, you should be able to do the small things with ophthalmoscope, as by putting a torch onto the eye and just examining the anterior segment of the eye to catch who are susceptible for glaucoma, and catch the glaucoma suspect, and then do the following investigations to make them to confirm the glaucoma diagnosis. The term when a patient, anybody having a family history, if somebody bringing a patient with glaucoma, their father, mother, or sister or brother, actually, then just advise them to get their eyes checked, because they also are more prone to get glaucoma in their future life. Therefore, always do not forget, if they have a strong family history, is one of the glaucoma suspect, then you have to advise them to at least check their eyes at least once in 4 years if they don't have any signs. And if they have any signs, then they have to just have a regular checkup as advised by eye surgeon. So therefore, strong family history and then if a patient having a high IOP, as Professor Madhavan said, will consider the normal IOP from 12 to 21. Actually, then more than 21, we label them as glaucoma. That means 22 and above. Usually, we suspect this patient may have glaucoma or may not. If they don't have other signs of glaucoma, we label them as ocular hypertensive, as they are having a repeatedly checked IOP will be very high in each and every checkup. Then go ahead and do the fundoscopy to see the optic nerve head. If there's any appearance of the optic nerve head clinically, will Professor Mandhavan show some pictures, and I will show more pictures to what the clinical diagnosis, how do you make by looking at the optic nerve head for make the patient suspect of glaucoma or the definitive glaucomatous optic nerve head signs. Not only the intraocular pressure, there may be other predisposing factors for glaucoma as discussed as pathophysiology. Then glaucoma. How do you determine the glaucoma suspect as a glaucoma patient? Confirm whether glaucoma is present by if they do have 2 or more criteria, what we have discussed in about slide. They have optic nerve head changes, high IOP, any family history, and the visual field changes on clinical diagnosis by doing a nerve fiber layer analysis or visual field testing. Any of 2 of them are positive, we label them as glaucoma is present. Then, is there any other glaucoma risk factors underlying? I will discuss what are the risk factors for glaucoma and exclude similar clinical diagnosis mimic glaucoma. Sometimes the patient may have normal pressure, but visual field changes show some glaucomatous signs. Sometimes it may not. It may be a neurological problem. Therefore, you have to be very careful to handle these glaucoma patients. Sometimes they may be a neurological, not the glaucoma. Then identify predisposing factors for secondary glaucoma as discussed. Then you should be able to just have some clue about what are the secondary causes, and then plan a treatment strategy and sustain suitable form of treatment, because it is a lifelong treatment. We have to just assess their social aspect and the economical, and whether they could follow up these drugs throughout their life. Therefore, it is the diagnosis history is where any diagnosis starting from the history. Therefore, history taking is very important as a medical student. Then you should not forget to talk with the patient, get the information from the patient to make any clinical diagnosis. Therefore, as you know, these are the common things you should ask from the history. I'm not digging into the deep what you should ask. Then any refractive state of the eye, especially high myopes, if they are wearing thick glasses, if they are very short-sighted, they are more prone to get glaucoma. Any chronic eye disease as a secondary cause, any trauma to the eye, any laser treatment, diabetes, glaucoma medication, and any topical treatment. Those things to be recorded in the history. And also the other related factors for the glaucoma are arthritis, especially they are on steroid, bronchial asthma on steroid, dementia patient, and the drugs they are taking may cause glaucoma. Sleep apnea causes raised superior vena cava pressure, also cause raised intraocular pressure. Then the pregnancy and lactation, those things also have a high pressure in the eye. And cardiovascular diseases, renal diseases, endocrine diabetic patients, thyroid and pituitary diseases, sometimes they may have differential diagnosis on their visual field defects. Then any central nervous system problem should be just noted because there are the differential diagnosis on their investigations. Then the pituitary tumors all are more liable with confused with the glaucomatous visual field defect. Therefore, past medical history is very important for the make the patient as diagnosed as glaucoma before starting the medication. Then there are many drugs can cause glaucoma, and any glaucoma medication also you should ask because the IOP may be normal because they are taking the glaucoma medication. As I said, long-term steroid, Parkinson drugs, topical eye drops, steroids, tricyclic antidepressant. Topiramate may cause acute angle closure glaucoma and myopia, and anticholinergic drugs, anticonvulsant drugs, alpha agonist, sulfur allergy, and carbonic anhydrates are contraindicated if we are treating for glaucoma. Therefore, drug history is so important for the favor in the diagnosis, whether provocating the glaucoma as well as for the management of glaucoma. Therefore, don't ignore the drug history. Then, after taking the proper history for the favor in the diagnosis, then we have to do the examination. Visual acuity is not very much important, but glaucoma does not cause reduced visual acuity. It causes reduced visual field. Then as routine, we do visual acuity, refraction, pupil examination. It's very important. In stage glaucoma, usually they have afferent pupillary defect with total visual field loss. External examination of the face, around the eye, lids, cornea, anterior chamber, iris, lens, and the gonioscopy to make the patient diagnosis with this primary or secondary as discussed in earlier topic, and intraocular pressure. Then the central corneal thickness also related with the glaucoma, and the optic disc and fundus examination and further in other investigation. Therefore, clinical diagnosis depend on what I have said. You have to just have a brief examination. You can do with the simple, very good pen torch. You don't have to always use the sophisticated slit lamp, because with your naked eye, you can flash the very good pen torch to see the patient's anterior chamber. Then this is the way. This is the main thing we are doing, because in our country, the most available treatment for glaucoma is IOP lowering drug. there are other causes, but now in the other foreign countries, developed countries, they have many other drugs, but very expensive. But in our country, our main treatment is lowering the intraocular pressure to hold the glaucoma progression. Therefore, checking intraocular pressure is very important. We can check with the slit lamp with the tonometer. That's a gold standard. And you can check with the then you can check with the this rebound tonometry. That's very easy. No need an anesthesia, less contamination. It's a handheld. You can train anybody to do this to check the intraocular pressure. Then slit lamp biomicroscopy with the direct ophthalmoscope, you can just look at the fundus to see whether the cup disc ratio. But in eye unit, we do with the indirect to have a three-dimensional stereoscopic view of the optic nerve head. These are the features which is more clinically favor of glaucoma diagnosis. Any asymmetry between the two cup disc ratios. Cup to disc ratio, I'll show how it's happened. If there's any discrepancy between 0.2, that means one eye cup disc ratio is 4, other eye cup disc ratio is 7. Therefore, the cup disc ratio 7 eye is more susceptible for glaucoma, and there's more, that patient is more towards the glaucoma. Therefore, cup disc ratio discrepancy should be less than 0.2 to be normal. If it is more than 0.2, it's more high risk. Then the vertical elongation of cup. Usually the nerve fibers losses in glaucoma, superior and inferior. Therefore, if that happens, the nerve fiber loss causes vertical elongation of the cup, the center core, due to damage of the superior and inferior nerve fiber layer. Then there's a isn't rule violation. I'll discuss that. And nerve fiber layer defect and hemorrhages, what you have seen in the previous presentation. Then make sure there's a RAPD. RAPD means relative afferent pupillary defect. Actually, you are learning these things in a neuro appointment as well as by doing the eye appointment as well as a medical officer. You should be able to detect the afferent pupillary defect with simple pen torch. If the pupil is not reacting to light, or this patient has a reverse Marcus gun, this patient have very bad optic nerve function in the afferent pupillary defect eye. Then I said you have to have a very good look with the face, because there are some clinical pictures which associated with the face and around the eye. They may have very high risk of glaucoma, as discussed with Professor Madhuvanti. I'll show some pictures to you. Then these are the conjunctival and eye signs which shows lid hemangioma, adrenochrome deposits, dilated episcleral vessels due to raised venous pressure, nevus of water, and evidence of any inflammation. Then the signs of glaucoma, Dr. Madhuvanti discussed. If the IOP is very high, the cornea is a bit lustreless. It's not clear. Clarity loses. And there's an epithelial edema. Then sometimes there's a stromal opacity due to some other reasons. The patients need to be put on steroid. And the Krukenberg spindle is one sign. You can see with the torch, actually, with a very good, if you have a good vision, you can see with the torch, right? These Krukenberg spindles also a sign of glaucoma due to pigment dispersion. endothelial cape, if there's something deposit in the cornea at the center or diffusely, these are the sign of uveitis, which may be a risk factor for secondary glaucoma. And HABs trial due to congenital glaucoma because it can damage the eye on forceps delivery. And this is our angle sign, Schwalber's line, which a sign of angle deorganization due to congenital problems, which may cause abnormal trabecular meshwork and angle structures. These are the other rare conditions which may have a high risk of glaucoma. And these are few pictures with trauma, pigment dispersion. Just get familiar with this type of any abnormal picture if you see in a patient, because you can't remember all those things, because these are more stuff, some more not actually can be detected with the torch. But if you just get familiar with the pictures, any abnormality of this iris, anything abnormal with the iris shape, and any gaps between the iris, any holes in the iris, new vessels in the iris, those things, if you see any abnormal things, that may have high risk of glaucoma. That is one of the clinical diagnoses which favors the secondary glaucoma, right? You don't have to remember all those things. We are showing these pictures and we are teaching these things because if you have iris atrophy, that may be a trauma or that may be a surgical trauma, patient may end up with glaucoma. If the inflammatory signs, what I have said, Dr. Madhavanti said, you said that there's a 360 degrees addition of the pupil to the lens cause iris bombay. Iris bombay and cause angle closure glaucoma. This is right around, can you see, this is bombay, cause angle closure glaucoma. Right? You can see with a simple pen torch with some of these signs. And the acute angle closure glaucoma, I'm not discussing. This slide was discussed nicely by Professor Madhavanti. And this is an emergency. That's a primary acute angle closure glaucoma. This is how it happens. And anything, it says, sometimes there may be other surgical things you see like this. You have to refer the patients for secondary angle closure glaucoma, blocking the pupil. And this type of thing can block the pupil by artificial lens or our crystalline lens to after trauma. Then you have to see the eye, whether there's any holes in the eye. Sometimes it may be treated with for glaucoma, and you are sure if the patient is having that peripheral iridotomy, if you see with the torch, that's you are 100% sure this patient is a angle closure glaucoma suspect or angle closure glaucoma patient. That's one of the clinical diagnoses. Then these are the other signs. Sometimes you might see traumatic impregnated of the pupil pigments on the lens, and if its pupil is dilated, you have seen that this indicates this eye had a trauma previously, and they are more susceptible for glaucoma. And the pseudo exfoliation is one of the common, very common secondary. Actually, we have done a survey. This is the commonest type of secondary glaucoma is traumatic subluxation or spontaneous subluxation due to Marfan Weiss-Marksani syndrome. There are many syndromes which cause spontaneous subluxation of the lens, like the spherophakia. They can come out to the pupil and block the pupil. And the cataract, the very white intumescent cataract, which swells up like a ball and blocks the pupil. Then these are the glaucoma flecken and the high walled lens. Lens can be having a high wall, especially when the females are reading in a dim light. Then they can increase the anteroposterior diameter and cause pupillary block. And it was nicely explained in the previous talk. Then you have to assess the open angle and the angle close. There are different ways to assess the degree of angle by having a simple slit lamp examination as well as with the pen torch. Usually, if you don't have a slit lamp, you can do this. Flash the slit lamp beam on the side of the eye limbus and see whether the depth of the light beam on the limbus and the light which falling on the iris on the same side. If it is, the width is very narrow and very close and touching equally, touching to the light beam externally, that means very narrow angle. If the light beam has a one depth of the beam we are reflecting, like this depth is same, that means angle is open. That's how you make the clinical diagnosis of open angle without gonioscope. This is a very easy method actually to with the simple pen torch, right? If usually the iris, the hydrocorneal, the area, the angle is wide, right? The light, if you apply the light onto the limbus, temporal side, it passes to the other corner and illuminate whole iris, right? This light passes through the cornea and there's no obstruction. It passes up to this side of the limbus and whole the iris is illuminated. That means the angle is totally open. But if the iris is pushing upwards and is this blocking the angle, is narrowing the angle, if you flash the pen torch to the limbus, this does not allow to pass, right? This is not allowed to pass, only pass and stop here. Can you see? This light rays which pass up to here and stop. Therefore, this part is dark and up to here is light. Make a lighter hammer. Kelinian is this a straight line. Therefore, up to this area is illuminated. From there, it is not illuminated. Like there's a shadow. That means angle is shallow. This is how you don't have to do a grading, but if you can detect this, there's a shallowness, this dark area, the shadow area is more than half of the iris. That means angle is narrow. Here, more than half is the iris again. If this half is shadow, that means the angle is shallow. This is very easily could be done by anybody, even from the medical student. Therefore, it is one thing to assess, to judge this patient has a narrow angle and very easy way. This is the most sophisticated method to assess the angle. All the structures we can see with the gonioscopy. Usually it is done at the eye unit by experienced person, but you can't do as a medical officer or medical officer in periphery. Then the central corneal thickness. Central corneal thickness measurements also needed for especially for glaucoma. The chronic glaucoma patients, long-standing chronic glaucoma patients usually causes loss of central corneal thickness because long-standing high intraocular pressure. And we also misled by the low central corneal thickness because they indicate low IOP than what should they have. Because when the corneal thickness is less and thin, its indentation is more easy by checking the intraocular pressure. Therefore, it just misleads us by lowering the IOP. And we also think this patient may not have glaucoma, but actually they have glaucoma. Therefore, low, thin central corneal thickness, less than 500, should have a suspicious of glaucoma always, unless it is proven. Because in our country, in my survey, we did a survey actually with the college, and their central corneal thickness is around 500 to 550 in our country. Therefore, very thin cornea, this is not our figures. Very thin is less than 500. Thin means 535, less than 525. Average 550. And thick means more than 575, and very thick is less than, more than 600 means cornea is edematous and very thick. This is the same. This is how you just examine the cup. As Dr. Madhurati showed these pictures, this is a disc. I said there's a disc has a disc margin. You should be able to highlight. You have to go examine the fundus, optic nerve head, with the ophthalmoscope and just find out the disc. And disc where the vessels are, that has the highest caliber at the disc. We have traced from the vessels. When it increases in the caliber, then you can catch the disc by looking at the ophthalmoscope. Therefore, disc margin, this is the disc margin, right? so margin of the disc, optic nerve head, and this is the peripheral orangish rim. Is the neuroretinal rim. This is the neuroretinal rim. This is the inferior one. This is the superior one. This is the temporal, and this is the nasal. Isn't mean inferior, superior, ISNT. Therefore, thickest is inferior, then the superior, then the nasal, and thinnest is temporal. Because temporal, the macular fibrous has a more volume, more area to pass through the optic nerve head. Superior and inferior fibers which are more vulnerable for glaucoma. That's why the elongation of cup, vertical elongation of the cup is very important, right? Here you see there's a neuroretinal rim has gone, damaged, and only with the 1% of the normal axons are now remaining. Nearly 90% of the axons has died, and only a simple rim of nerve fiber layer are there. It's a very advanced glaucomatous patient. Yeah, there are other signs.
Sorry, I'm very sorry to disturb a very interesting presentation, but will you be able to kind of summarize in about 5 minutes?
All right. Yeah, I'll go to the investigations there, right?
Yeah.
Okay. Then these are you have to get familiar with this notching, hemorrhage, and the pallor. And these are the other secondary causes of hemorrhages, venous occlusions, and chronic stages. And these are the visual field changes. You can get to the glaucoma. More advanced stages, you can go to the total loss of visual field changes. And these are the, and they are the early changes, not very early changes with inferior rim thinning. And these are the bottom one is advanced glaucoma. And these are the optic nerve changes. You have to do the ganglion cell analysis of the glaucoma patients with OCT. And this should be analyzed by a specialized. You should know these things should be done to make the patient diagnose glaucoma. And the take-home message, if you are dealing with a glaucoma patient, to make them diagnose as glaucoma, therefore, a good history, eye examination, pupil examination, detailed slit lamp examination, and check IOP and check the central corneal thickness and do the investigations of visual field and OCT to make them confirm as glaucoma. Thank you very much.
Thank you very much, Dr. Lalita, for that very interesting and informative presentation. I think your explanations were very good. I think a lot of people would have benefited from that.
Okay, thank you. Thank you so much. Okay.
So next, I would like to invite Dr. Pradeepa K. Sirivardhana. She's a consultant eye surgeon working at National Eye Hospital, Sri Lanka. And she's also the chairperson of the Glaucoma Interest Group, College of Ophthalmologists of Sri Lanka. So actually, she is the pivotal point or the central point of all these glaucoma, World Glaucoma Week activities. So we would like to invite you to address the participants of this webinar. Over to you, Dr. Pradeepa.
Can you see my screen?
Yes, we can see. Yes. We put it to the presentation mode. We can see the slides.
Okay, yeah.
Yeah. Presentation mode would be better. Slideshow mode. Yes, we can see now.
Yes. Good evening to all of you. At the outset, I'd like to thank Professor Madhuvanthi Sanayaka for inviting me to make this presentation. I think it's not in the Is it in the presentation mode? My screen?
No, it's not.
No.
No.
You have to make presentation mode.
Yeah. So it's a chronic disease, and when we treat glaucoma, what we really do is we lower the intraocular pressure, because as far as we know, the only thing that can be controlled in glaucoma is the intraocular pressure, and only that can prevent the progressive damage to the optic nerve. So the treatment available is medical treatment. Then laser treatment may be used in certain types of glaucoma, and then the surgical treatment. Now, most patients are treated with medication, who are on lifelong medical treatment and who retain vision. But you have to continue the medication according to the correct dose, and you have to use the medications every day so that your intraocular pressure can be kept lower. But although you're on medication, the intraocular pressure has to be assessed, and then the other tests that assess the progression of the disease also have to be done. Then now patients who may be resistant to medical treatment, that is, even with the maximum medical treatment, if they don't respond, if their intraocular pressure remains high, then they may have to undergo surgery. Then there are patients who are not compliant, may not be compliant with the treatment, or may not be compliant with the follow-up. So they also, it is recommended that they also should undergo surgery. Then there are patients who cannot tolerate medications. Now, most of the medications are topical, but there are many patients who surgery. But whatever treatment that is done, they need lifelong treatment and follow-up, because glaucoma is cured and the damage cannot be reversed. So now Professor Madhuvanti Disanayake went through this slide. Now, to understand about the medical or surgical management of glaucoma, you have to review this, the production and the drainage of aqueous humor. So aqueous humor is produced by the ciliary body, and then it drains through two routes. She said it drains through the conventional trabecular route, and then it also different medications act on these different pathways. There are medications that reduce the aqueous production, then there are medications that enhance the outflow. Now, the medications, the important thing about medication is that even topical medications can have systemic side effects. So now, this is most noticeable with the beta blockers, topical beta blockers. Now, beta blockers, they have been used over a long time. They reduce the aqueous production. What is commonly used are the timolol 0.5% and betaxolol 0.5%. These are used BD. But the problem with these are that they get absorbed. Drugs get absorbed when they are put into the eye, because they enter the nasolacrimal duct and then the nasal cavity and the nasopharynx. And this is a very vascular area, so they get directly absorbed into the bloodstream. And topical drops, unlike the systemic or oral drugs, do not undergo that hepatic metabolism. So a drop of timolol may be as potent as timolol taken systemically. So the side effects are there, especially in patients who have heart block, patients who have chronic obstructive pulmonary. Find out whether a patient before we usually check history of asthma in a patient who may. Then there are the alpha-2 agonists. They increase the outflow mainly through the trabecular meshwork, but also through the uvascular meshwork. Brimonidine is the one that it has a lot of side effects, but it is a very potent drug used if you want significant reduction of the intraocular pressure over a short period as a patient with an acute tangle closure. So it is the drug to use, but not recommended for long-term use. Now, topical carbonic anhydrase inhibitors, brinzolamide, dorzolamide, they may be used BD or TDS. They are not very potent. They are not. They do not cause a significant reduction in the intraocular pressure, but they do not have the side effects of the systemic carbonic anhydrase inhibitors. Then come the prostaglandin derivatives. These came in the late 1990s. So these are now considered the first line of drug. Topical, now they are given once daily, so the compliance is good. Latanoprost, travoprost, bimatoprost, they are used in the night, so that improves the compliance. These do not have any systemic side effects, but they have ocular side effects. They increase the color of the iris, which may be a problem in people who have light irises. Then other thing is they cause pigmentary changes, growth of lashes, and they tend to cause orbitopathy, where the fat around the eye atrophies and the eye appears sunken. Miotics, these topical drugs like pilocarpine, they were used in the past, commonly used, but now we rarely use them. Maybe in a few instances, like in acute tangle closure, before you do a laser, they may be indicated. So other disadvantages, they constrict the pupil, and they have to be given 4 times a day. Then the hyposmotic agents. Now these are used when there's an acute increase in the intraocular pressure, as in acute angle closure. So these are like mannitol, so they are given once to bring the pressure down if it is very high. So now I have listed the drugs and their side effects in this slide. And one thing to remember now, even these topical drugs have systemic side effects. So to minimize systemic side effects, you need to train the patient to properly instill the drug, so that they can instill the drug and close their eyes and apply pressure over the nasolacrimal duct area for some time, so that it will get absorbed into the eye without going into the through the nasolacrimal duct and get absorbed into the body. Newer drugs are there. We don't have these drugs. So these include latanoprostene Bunod. It is a prostaglandin analog. So it increases the outflow through the trabecular meshwork and also improves the uvascular path outflow as well. Then the other drug is netazodil. It belongs to a group called ROCK kinase inhibitors. So these are involved in changing cell shape, so that these increase the outflow through the trabecular meshwork, and they also may have a role in decreasing the production of the aqueous humor, and they may also decrease the episcleral venous pressure against which the aqueous has to flow out. Laser treatment for glaucoma is used in certain instances. Now, laser trabeculoplasty is something that is used for open angle glaucoma. It does not cause a significant decrease in the intraocular pressure, but in patients who have mild to moderate glaucoma, it may reduce the number of the medication that a patient uses. So here, the coagulation treatment is done to this area of the trabecular, of the angle that is between the pigmented and the non-pigmented areas of the trabecular meshwork. So this is supposed to either cause scarring and then strip the trabecular meshwork, or it may be causing some biological changes. Currently, there's another mode of treatment called selective laser trabeculoplasty. Then it is the area where you want to treat, and it is supposed to be a safer and more efficient than argon laser. Then the other instance in which we use the laser is to manage an attack of acute angle closure, because now the previous lecturers explained about this the mechanism of acute angle closure. So using the laser, you can make a hole in the peripheral part of the iris, so that you establish the communication between the anterior and the posterior chambers, and thus open the angle. Now, surgery, I told you in which type of patient surgery is indicated. So the types of surgery available are trabeculectomy. This is the surgery that has stood the test of time. It is still done. It is indicated for patients who have severe glaucoma and who need a significant reduction in the intraocular pressure. Then there are the drainage devices. Then there are the cytodestructive procedures. Cytodestructive procedures are used to destroy the ciliary body and reduce the aqueous production. So these are generally used in patients who do not have that much of a visual potential, because these can not be controlled. So the ciliary body is destroyed either using cryotherapy or diathermy or even laser. So the other two methods are generally used for patients who have a good visual potential. So this slide shows the picture of the eye that has undergone trabeculectomy. So you see this bubble. This is called a pleb. So what is draining out of the anterior chamber is getting collected in this small subconjunctival cyst, and this is being drained through into the subconjunctival veins and then out of the eye. And this diagram shows how this works. So now in primary open angle glaucoma, it is generally believed that the obstruction lies at the level of the trabecular meshwork. So what is done is that a fistula is made. So a flap of sclera is made, and then fistula is made into the anterior chamber, and then there's the graded controlled flow of the aqueous humor out of the eye under this flap, and then it is absorbed into the subconjunctival veins. Now, glaucoma drainage devices. So this is what a glaucoma drainage device looks like. The same principle as in trabeculectomy, but more controlled drainage. Here it has a tube, and then this tube is inserted into the anterior chamber, and the fluid drains inside this chamber, and from these holes it leaks out. So this diagram shows now here the device, the chamber, and this is the tube in the anterior chamber, and through these holes it drains into the subconjunctival space. Now this is indicated. Now, trabeculectomy, the problem with trabeculectomy is it can close due to scarring. So in patients especially in young patients, in patients who have had multiple surgeries and certain types of glaucoma, these are better than trabeculectomy because they have a lower chance of scarring and failing. And these are various types of devices. In our country also we use certain devices. Now the current mode of surgical treatment is minimally invasive glaucoma surgery or MIGS. So now this is generally used in mild to moderate glaucoma when you don't need a significant reduction of the intraocular pressure. So either various procedures are done in the angle or various devices are inserted into the trabecular meshwork area. Now this usually these surgeries are performed with cataract surgery. That is when a patient undergoes phacoemulsification, one of these devices are inserted so that the patient will have further reduction of the intraocular pressure and will not need that many medications to control the pressure. And in future, in case in future the patient needs to have safety profile, and then there's rapid recovery. So these are the different types of devices that are used. So now this diagram shows this is a procedure where the Schlemm's canal is open, and this is also a diagram of a device that can be inserted. So this slide shows the various types. So some filter aqueous into the conjunctival space, then some involved in opening the Schlemm's canal, and some drain the aqueous into the suprachoroidal space. So like that. But now when we talk about glaucoma, now we know the only control risk factor in glaucoma is the intraocular pressure, and all the treatment is done to control this intraocular pressure. But intraocular pressure is affected by other things also. So until we find something else to protect the optic nerves, we will have to continue to manage to keep the intraocular pressure down in patients with glaucomas in order to save their sight. Thank you for your kind attention.